Anyway, it's so nice to be here and actually to see you all. And, you know, I recognise so many faces from the Brompton, and then there's lots of other new faces as well this year, which is really nice to see. But I think what we wanted to do in what is pulmonary hypertension, we wanted to demystify what this condition is, so that everybody has a basic understanding of what the condition is, so that when we talk through the rest of the talks in the day, you understand why the medications are given for the reasons that we prescribe them. But I think at the very beginning, what we need to know, though, is what is normal and why is it that your lungs and your heart change, and hopefully we'll demystify that.
Yeah. To start off with, I think to understand what pulmonary hypertension is you need to understand what's normal. And as I'm sure you'll all know, your body has two circulations. And the main circulation that everybody talks about in the normal high blood pressure is the circulation that goes all the way around the body. That's the blood pressure you can measure in your arm. And very often in pulmonary hypertension, that's quite low. And it's really frustrating. Some of our patients, when they go back to their family GPs with a diagnosis of pulmonary hypertension, will then get their blood pressure checked on their arm and be told it's low or it's normal, and what are they talking about in the hospital? So I think the big thing is to realise that we're talking about the circulation that goes through the lungs. And these two circulations don't normally meet, they're very different pressures. The pressure that's in your blood pressure you check on your arm has to be high, because the blood gets pumped all the way around your body, up to your head, down to your feet, and then has to come back into the right side of the heart. The circulation through the lungs is much, much lower pressure. And if you could put a blood pressure cuff over it, it would be something like 20/10. Compared to your normal blood pressure, it's like 120/80. And the lungs work really well at low pressure. And the lung blood vessels is not just one tube that goes through. As you'll see from the picture here, there are thousands and thousands of little blood vessels in the lungs. And so sometimes the questions that patients ask us is, why can't you stent a pulmonary artery it's got high blood pressure or that's blocked? It's because there's not just one, there's lots and lots of them.
Hundreds and hundreds.
Hundreds and thousands of them. You'd be stenting all day. Actually, you wouldn't be able to get to them. And these blood vessels all surround the air sacs that are in the lungs with a capillary network. And it's these tiny little blood vessels that often get affected in pulmonary hypertension. And that's why the oxygen doesn't flow quite so well into the bloodstream. There's not so many blood vessels there. So in the normal circulation, if you go to exercise, the blood vessels will open up, let lots more blood go through the lungs, and pick up lots more oxygen. And as you'll see, as it goes through the little air sacs, they go from just having a tiny blood supply to having a big blood supply. And that's how your normal body would work. So when you're sitting at rest, you don't get much blood through the lungs. When you go to exercise, the heart pumps harder, you get many more litres going through the lungs, so you can do things like walking upstairs without any problem. And as Carl will show you, in pulmonary hypertension, there are some changes.
So you can see the blood vessel, the way we've represented it there with the tight lumen, or the way the blood flows into the pulmonary arteries is very narrow. And what you can see is that because of the blood vessel becomes narrow and thick, which Wendy will describe more in a minute, the pulmonary arteries are non-pliable and they become stiff. And they can't engorge the blood to pick up the oxygen. And that's why you end up being breathless. Because they're non-compliable to the blood moving forward in a great volume. And the reason that is because you're producing substances of relaxation in low levels, and all the constricting, tightening substances you're producing in excess. And that's because of the changes in the pulmonary anatomy. Wendy can really describe that a bit further.
I can. Have we got a pointer anywhere? I've got an arm. Fine. So as you'll see on the far side of the little cartoon here, that's your normal blood vessel. The little dots going through the middle are going through your nice open blood vessel. And we know in pulmonary hypertension, the cells in the middle of the blood vessel, the endothelial cells, and you'll hear about that when you're hearing about drugs later, you get far too many of those produced, and they send off lots of signals saying, squeeze down. The muscular layer of the blood vessels gets a lot thicker, and then the other layers of the blood vessel also become thicker, so the space the blood has to go through is much, much tinier towards the end. And it's like Carl was saying, if the space you've got to go through is much tinier, then the pressure has to go up. It's a bit like a garden hose pipe. If it's flowing with a nice open pipe, it's okay, but if you start squeezing it, you'll either get a very fast jet at one end or you'll get some coming back into your face. Oh, I can use it later. So Carl's just going to explain about normal hearts.
So if you look at the right side, or where it's all coloured in blue, you can see that the wall is nice and thin. And you can see on the left side, which is sort of reddish in colour, it's nice and thick. And that's because, as Wendy said earlier on, the left side of the heart has to pump blood all the way around, down to the toes. And that's a long way, actually. And then it's got to help bring it all the way back up into the right side. But the right side has only got to go from here and all the way around here, and that's it. But in terms of pulmonary hypertension, when it's trying to fight through those blood vessels, Wendy will now describe what happens in the pulmonary hypertension heart.
I was also trying to work the pointer that I can't actually manage. So in pulmonary hypertension, to cope with that increased pressure in the blood vessels in the lungs, no, this doesn't work. You'll see the right side of the heart, the muscle has to get thicker, the right side of the heart gets bigger, and it actually then tends to squash the left side of the heart, and that's why your normal blood pressure is sometimes lower. So the right side is quite good at remodelling for a while, but when it gets too big and too muscular, the left side is squashed, so that doesn't fill as up enough, and that will often then drop the amount of blood that the heart can pump around the rest of the body.
Just one thing before we go on further, there are some patients with pulmonary hypertension who don't always meet that failing right ventricle in the early stages of, or in the early part of their life, and that's the congenital group. And it's important to remember this, because unrepaired congenital patients who've got holes in their heart, they'll get the nice thickening of the muscle like that you see there on the right side, but the actual pumping mechanism in many of them can be kept good for a long time. And it's just they're just one variant of pulmonary hypertension that's a little bit different, but ultimately they do get the same type of symptoms in the end as every other patient. And
one of the treatments that may be offered sort of in the future is sometimes to make a little hole between the top two chambers of the heart to help protect that right side of the heart. We don't tend to use it very much in adult patients, but it's used a lot more in children. So what happens with pulmonary hypertension? We get the signs and symptoms, and I'm sure you'll all know these. The early signs and symptoms, which are confused with just about every other respiratory disease or being unfit, is just a bit of breathlessness when you're starting to exert yourself and you're more tired. And I know certainly from the data that's come out of the patient survey and the people that I know in the room with their stories as well, they will have had symptoms for quite a while. Sometimes put it down to being maybe a little bit older, a bit more unfit, perhaps having had a chest infection or something. And often it's a little while before you seek medical attention. And then the doctors themselves, when you first go to them, rule out all the common causes such as asthma, COPD, being unfit, being overweight or anything like that. So it often takes a very long time to diagnose because these early symptoms are quite non-specific. And to be honest, most GPs will only ever see one patient with pulmonary hypertension in their lifetime. So almost they could be forgiven for not thinking on it at the top of their list, but it certainly does need to be on their list of, once they've ruled out the common things, could it be pulmonary hypertension? And this other symptom of early satiety is quite common in pulmonary hypertension. It means that when you've started eating a meal, that you're full up very quickly. And that's often because the pressure on the right side of the heart makes the gut a little bit more edematous, makes the liver bigger. And so when you have a small meal, your stomach feels as if it's eaten a huge meal. So that's also a very common early sign. So really it's small meals and often if you've got PH, but I'm sure you all know that. And then in the later stages, you can develop ankle swelling. Some patients have blackouts and some present in hospital with coughing up blood. And over 33% of the patients that are diagnosed with pulmonary hypertension, their first diagnosis, the first time somebody looks at it, is an emergency hospital admission, which is awful, really. So, and that's normally because they've fainted or they've developed heart failure or they're so breathless they've had to call an ambulance. So we really need to work as a PH community to get an earlier diagnosis.
So looking on, sorry, I was going to introduce. So when you come to clinic and you see the nurses and the doctors mainly, they press your tummy, they listen to your heart, but do they ever really tell you what they're doing? And do you understand sometimes what the doctors are saying? Because they've normally got somebody, one of the fellows or somebody's learning pulmonary hypertension in the clinic, and you hear all these terms. And Wendy's now going to try and demystify again these terms that we use in clinic.
So this is what we say when we're talking to other medics and healthcare professionals. What do you look at for pulmonary hypertension? So this increased intensity of P2, I don't know if anybody's heard, when they sort of say your P2's loud, it just means a second heart sound. And that's increased because of the increased pressure in the heart. So when they're listening to you, very often they'll get you to stop breathing for a little while so they can actually hear your heart sounds. It's not always present, but once you've heard it once, you'll pick it up on more patients with pulmonary hypertension. This right ventricular heave they talk about, because the heart is bigger, it twists slightly, and you can often feel, certainly when you've got quite severe pulmonary hypertension, you can feel your heart beating out your chest. Do any of you feel that sometimes? And if you're actually feeling somebody's chest, you can sometimes feel that right ventricle just tapping the side of the chest, and in normal health that shouldn't happen. I said you can hear these murmurs of regurgitation through the jet on the right side of the heart. And we also look at everybody's necks, and I'm really sad when I'm standing in Sainsbury's queues, I look at people's ankles to see if they're swollen, and then I look at their necks to see what their JVP's like. Other people look at, magazines on the rack, but I tend to sort of try and work out why people are sick. And the JVP that we'll often look at is to an estimate of how high the pressure is going back into the heart. And if this is too high, we probably need to increase your pulmonary hypertension meds or increase up your water tablets. So you'll often get people, you'll notice the doctor will ask you just to look to one side so they can see what your neck's like.
And they might press.
Yeah, I don't tend to press.
They tend to dig to try and push the vein up a bit more.
I'm too lazy to press, probably. And in some people, the pressure is so high, you can almost see their ears waggle. And we say, if you get to that sort of stage where your earrings are waggling every time that your heart's beating, you probably need a little bit of an increase in your meds.
And not a night out.
You can get peripheral edema, so you can get ankle swelling, and we're often checking to make sure you've got ankle swelling. And I'm sure you'll know the way of working out is if you've got larger ankles yourselves or naturally, or whether you've got fluid in them, is to poke your finger in, hold it there for a few seconds, and then take your finger out. If it's exactly the same as it was before, sadly, that's your own ankles. If you leave a big dent, it's fluid. And sometimes the fluid can go all the way up. And so I have seen people with fluid that has started in their ankles and has gone all the way up to the top of their chest. But if you've got any swelling in your ankles or your lower limbs, it's likely that your liver and your gut are a bit swollen as well, because they swell up first.
But all the Brompton patients would know not to do that. They would come and they would get it all sorted so they get their skinny legs. Is that right? Brompton patients?
Yeah, so don't wait till your swelling gets up to here.
Please.
Get it sorted out earlier. So we're always looking for peripheral edema. And when we sometimes feel in your tummy, if there's any concerns that you've got more increased pressure, we'll feel for the liver. And I said the liver gets bigger because the blood goes through it on the way back to the heart, so it gets engorged. And sometimes you can get abdominal swelling, and that is often a real problem. So when you go to the GP saying, I feel breathless walking up hills, I'm really exhausted, my tummy's more swollen, the very first thing they do is put 2 and 2 together. They make 5 and they say, you need to go on a diet, which doesn't always work. So you get abdominal swelling often before you get ankle swelling. So we just need to look out for that. And we always check to make sure there's any fluid that's in the abdomen. And we know from pulmonary hypertension, and this is a very old slide that we've used for many, many years now, that in the very beginning, as the pulmonary pressures start going up, you're in this pre-symptomatic stage. You're absolutely fine because your heart is compensating for the increased pressure. Over this time, your heart's getting a little bit bigger, becoming more muscular, and you probably won't know that anything is wrong at all.
Remember that PVR is the resistance by which the heart is trying to push through. So in the normal heart, it's... But in pulmonary hypertension, it's... So you've got that force by which it's fighting against.
So the resistance goes up, the pressure goes up, and the cardiac output, the amount of blood that the heart can pump around the body, to start off with, stays absolutely fine. And that's on gentle, exercise as well. So by the time that you would normally get symptomatic and you come to see us, you've had pulmonary hypertension for a while. And with everybody, it's different. But often it can be for quite a long period of time. So normally in this middle bit, when people start to look for medical attention, they've already had pulmonary hypertension, and it's a stage where the heart is saying, actually, I'm not really happy with pumping at this level. And as we know, as the cardiac output, as the pressures increase, gets less, you're able to do less exercise, and the pressure in the top chambers of the right side of the heart goes up. And that's why we're so keen on measuring it at cardiac catheter, to know what the right atrial pressure, that pressure in that top chamber of the heart is like. Because it's a good indicator of how well your heart is working. So Carl is now going to explain about all the different types of pulmonary hypertension.
So hopefully this describes it in a much nicer way than you see in all the literature about what pulmonary hypertension actually is. Hopefully you will all know by the definition that it is a pressure that is 25 millimeters of mercury or more. Because it's important there that we need to know what a cutoff is in terms of how we diagnose pulmonary hypertension in patients and people. But there are different types of pulmonary hypertension, and only group 1 is called pulmonary arterial hypertension, and it is one of the main treatable groups. But it's also important to know there are other types of pulmonary hypertension which not necessarily respond to therapies, or therapies can sometimes be more harmful for them, but it's important to include them in the pulmonary hypertension population and be our friends within the association. Because at the end of the day, they still have that diagnosis too. It just means that their treatments will be different. And those groups include, of course, the second group, which is left heart disease. And the reason why left heart disease patients can't respond to therapies is as you flood the lungs with blood because you're helping the right side of the heart, the left side can't cope with that volume. And as it's trying to struggle to push through, basically you'll probably get a lot of blood staying in the lungs and it doesn't move. And then that makes a lot of complications for patients with left heart disease. The group 3 patients with lung disease, again, they tend to have lots of big, I want to say holes in their lungs, because that's the best way to describe it when you see their images. But what you see is the oxygen transfer and the carbon dioxide mixing, or the gases coming back and forth, are altered. And that is when you give these drug therapies to them, what you can do is you can make them more hypoxic, so their oxygen levels go down, and therefore they tend to, and because hypoxia causes, or low oxygen in the blood is the best way to describe it, causes constriction of the blood vessels, that can make pulmonary hypertension worse in those groups. I might be simpling it, but this is the general gist of why these patients do not do well on therapy. And need to understand it because we can give them other medicines. The group 4 patients, of course, are the thromboembolic, and they do respond to pulmonary hypertension therapies. And of course, they can also have an operation that sometimes takes away the condition itself. But they need follow-up just in case they progress to get pulmonary hypertension further down the line. And the last group, which is the big mix-up of patients of different types of different types of conditions. I was going to say etiologies then. I thought, who would understand that word? I don't understand it, so I thought I'd better simplify it by saying lots of different types of conditions. And that group of patients includes patients with sarcoidosis. And that's another treatable form of pulmonary hypertension within the UK. So it's understanding the groups, but equally we need to know about them as healthcare professionals and you as members of an association, because they are all represented within one umbrella, and that is pulmonary hypertension. Just want to say one thing about the group 1, because that's got lots of subgroups of treatable conditions. So that includes the idiopathic, the heritable, congenital heart disease, the HIV group, and the schistosomiasis. Well, I think I said that without swearing. Is a group of patients which you don't see in this country, and that's caused by little eggs from an insect in the lungs, and it's more of a South American type of, because the prevalence of that in the world is higher than anywhere else. But these little eggs, you'll be glad to know, are not in the UK.
And we do have some patients with schistosomiasis.
Do you?
Yeah.
Wow.
We've come from other countries, so it's something that we do still have to look for in this country of people that move around everywhere.
I've never met one yet, but that's not to say I won't in my future career if I stay in pulmonary hypertension, which I will, of course. And that's it. I think understanding that there are 5 groups within the first, so group 1 are the treatable groups, as group 4, and a small number within the group 5 patient population are treatable. But there are other reasons, but it's to understand that pulmonary hypertension is just more than one disease entity. It's lots of things.
And I will just say on the patients that have idiopathic or heritable pulmonary hypertension, that Carmen's outside, if any of you have seen her stand, what we're trying to collect is more and more genetic information about people and their families with pulmonary hypertension. So it's idiopathic, heritable. I think it's just those 2 groups at the moment. So if you've got any other family members who'd be interested in giving blood, go and see Carmen. She can give you more information, and we would be very grateful because we need to understand more about the disease. So I'm just going to talk a little bit about who gets pulmonary hypertension. Anybody, any age, any race, either sex, and isn't particularly anything that you've done in your life that will make you predisposed to pulmonary hypertension, unless you've taken some of the drugs and toxins that we know that are associated, things like cocaine, amphetamines, and in America they're having a real problem at the moment with crystal meth. And we do know that sometimes some of the slimming tablets that were taken several decades ago can be linked to pulmonary hypertension. So it's between sort of 15 and 60 people per million, so it's a rare disease, and each year for pulmonary arterial hypertension, we diagnose about another 5 cases per million each year. And the median age has changed a lot in the last 20 years, and certainly when Ian and I first started, patients were in their sort of late 20s, average age, young women with young children. And it's now being picked up in much more of an older population, and our average age is around 60 now. And you can see that from this just gender and age distribution map, and this was from the statistics that were out in 2014, but it really hasn't changed very much. It's just shifted slightly more towards the right. And you see, there are a lot of people that are developing pulmonary hypertension now in slightly older life, and with a proportion of patients in their 80s and some even older than in their 90s. So at any stage, pulmonary hypertension ought to be considered.
Do you think, Wendy, can I just ask you about this and repeat the question? Do you think that's because we're looking for it in a wider population and it's become more prevalent?
Yeah, I don't. So Ian was saying, is it because we're looking for it, or is more people getting pulmonary hypertension? But I think it's because in the slightly older population, perhaps in the past it was put down to the fact that they smoked, they had a bit of COPD, they were old. What do you expect? You get breathless. And actually, nowadays, that really isn't acceptable at all. And I think with people wanting more and more for their health, more people are getting investigated. And quite a significant proportion of a slightly older population have chronic thromboembolic disease. And for a lot of those, they can have surgery and be cured. So really, it's absolutely no excuse not to investigate breathlessness, no matter how old you are.
But I think it's also important to say about awareness in that, because awareness has not really changed that much in terms of the general practitioners and the general hospitals. And if you look at the impact survey, which is really important, If you see in there that patients are still seeing up to 4 doctors before they get diagnosed, they're still taking 2 years to get that diagnosis. So things haven't really changed in that perspective, but we are seeing an older population of patients, people coming through with a diagnosis, which is important and good. But I think the fundamental things for us to remember as people who work with the PHA, and you as members of the PHA, is that awareness and needs to be at the forefront of getting more people, because what we should be seeing equally is an increase in the younger age groups as well. So not just the older patient.
Can I just ask, with the younger generation, I think it's lower because they might get tired, but they just think, well, I'm trying a bit too hard and I'm young, so they might be not seeing somebody. Whereas when you get a bit older, like you say, they do tell you when you're getting older and unfitter. Maybe somebody like I was who's trying to keep fit, then I read the signs, but maybe might have had symptoms when I was younger, but ignored them because I was younger. So, no, I know there's a lot of young people got it, but do you think there's a lot out there?
But you might have, there's 2 points, there's 2 parts to that, Julie, that you could have been going to the GP and he could have been, or she could have been saying, oh, you're too young to have anything wrong with you. But you need, the classic asthma diagnosis and whatever. And the other thing is about people who are young, approaching their middle ages as well, is that you'll think, I'm not as fit as I used to. I don't go to the gym. Not that I ever went to the gym, but I mean, but there's always an excuse. And I think that's the important thing from the impact survey again this time, which shows that patients are actually delaying going to see a doctor about their symptoms up to 1 year. So patients are actually develop, and I don't think, in terms of pulmonary hypertension, as you can see, it's from Wendy's, the graph of where the PVR, the resistance was going up and pulmonary hypertension was going up. It's a progressive disease. So even if you did go earlier, you might get treatment earlier, but there'll never be a cure to that time frame. It would just mean that you'd get seen and hopefully treated a lot quicker. But I think that's the answer to your question, is that patients are actually delayed. We know now they're contributing to the delay because they just make an excuse for more breathlessness.
I know the other thing that I will say is that as you get older, you collect more comorbidities, other diseases that are going on. And so 20 years ago, it's quite easy. You either sort of had idiopathic disease because you had nothing else wrong, or you had congenital heart disease, where you'd see a hole and you know what it is. A lot of our MDT discussions are looking at everybody's investigations, trying to work out what's driving their symptoms. They might have a bit of lung disease, a bit of heart disease, a bit of arthritis, and it's really seeing what is actually driving the pulmonary hypertension and what we can do to improve the symptoms and their quality of life. So it makes our life a little bit more challenging, but very enjoyable. And so the last slide I'll just leave you with, and it fits in quite nicely, as Carl was saying, about sort of the whole journey to diagnosis. I've been doing some work with one of the pharma companies about producing a global patient charter. I think we're very lucky in the UK having the Patients Association and set up specialist centres, but it's not the same around the world. This is just a cartoon of some of the things that we were actually talking about on the day. We had somebody who scribed the whole time. And this was sort of describing the ideal journey. So really limiting that time to diagnosis, but then giving them expert care all the way through and involving patients in their joint decision making. And it really fits into the whole sort of theme of this conference and what we're about, is that, we're with you all the way through your illness, and it's #StrongerTogether.
How would you do it then? Do the hashtag thing?
Yeah, we were just deciding that not Britney Spears acts, but we were just sort of saying, was it #StrongerTogether? So a bit later on.
Do you like that?
Well, that's all you're going to get of me dance move-wise. I don't do dancing. But yes, and it really is true that together we're much stronger.
Well, I'm not going to patronise you, but it's the first time we've done a joint Woodies PH together, and I've got to say I think that's one of the best explanations of PH that we've had in 20 years. It's really good.
I'll get you the drink at the bar later.
Yeah.